so which is why we're going to put this up for them. Okay, so that's great. So thank you everyone for shifting the class over from the usual Tuesday to Wednesday, and also well done for getting using MS Teams. All done very well. So just some housekeeping for this entire session. For this webinar, what we'll be doing is I'll be doing a sort of like an interactive interview between myself and Mrs. Ruth Bradley, who is a clinician. We've invited her to talk to you about her experiences of telehealth and telerehabilitation. So throughout this entire session, it'll be nice if you actually mute yourself. If you're not contributing at any point. The reason for that is not because you don't want to hear you. It's just because if there is someone, sometimes there was one end and the sound travels to that room, what happens is that it has got feedback. So it makes it much more difficult to hear. So at the end of the interview, there will be an opportunity for all of you to ask any questions you want to Ruth. And so what I'll probably ask you to do is to raise your hand. So all of you would see on your MS Teams the raise hand function. So what I'll do is when that session opens, I will ask you to raise your hands if you've got any questions, and then just click on that, and then I can see who has raised their hands. And then when I call you, simply unmute yourself, and also if you want, share your video as well, because actually the MS Teams is quite powerful. So which means that the bandwidth isn't such an issue as compared to Collaborate Ultra. So you can actually share your video, and we would like to see your face as well, so that Ruth can actually speak directly to you. So just as a practice, would everyone mind raising your hands? Excellent. Well done. As you can see, once you raise your hands, you light up. Okay, which is very different to Collaborate Ultra. So I would know that you have actually raised your hands. So well done, everyone. If I can get you to put down your hands. Okay, great. Right. Out of the way, let's start the session proper. So we are very honored to have Ruth Bradley join us today. Ruth, I've known her for some time now, and we worked in various capacities. I mean, I met her after she graduated properly, when she was doing her courses with the Society of Musculoskeletal Medicine, where she was there training to become a teaching fellow. And I think you've got your teaching fellowship, haven't you?
Oh yes, almost just one piece of academic work and I'm there. So fairly nearly a fellow.
Yeah, so she is a very experienced clinician, but also a teacher of other clinicians as well. So it's actually we are actually quite lucky to have her today to speak to us about her experiences with using telehealth and telerehabilitation because of all the COVID situation, and therefore clinicians having to adapt. So welcome, Ruth. It's nice to have you here.
Yeah, it's lovely to be here, actually. It's nice to know that you're all out there listening along. It's nice to be connected.
Now, can I ask you, can you just kindly tell us a bit about yourself and also about your professional background, so that the students have a bit of idea of where you're coming from?
Yeah. So good question, because end of 2020, probably not where I thought I would be, because this year has thrown up a huge heap of things, some nice challenges, and actually it's opened up some really great opportunities. Currently though, I am a private practice MSK clinical specialist working in Edinburgh. I've worked in this role for a couple of years, and now I also teach and specialize in Pilates. So that's kind of the other arm to my kind of private practice, would be teaching one-to-one and small class Pilates. Bit about me in terms of my career. So I started in the NHS, just doing my kind of general rotations. I worked through a number of specialities in the acute setting within Edinburgh, the Royal and Western General, so two big teaching hospitals. I quite quickly thought MSK was my route, so specialised in MSK. and then moved into private practice. I've done a number of other little things along the year, work in rugby, work in some high level rugby, worked in rheumatology as well. So I've had, kind of a lot of different experiences over the year that have brought me to this point in private practice.
That's great. So you basically have a very extensive clinical background, and that obviously a lot of times before COVID, all your clinical practice was mainly face to face. And so tell us, when was the first time you started using telehealth in your own clinical practice?
Yes, that was a really good question, because I thought, have I ever done telehealth? I've done telephone calls in terms of chatting to patients over phone, but that would always have been in and around seeing them face to face. And I was thinking, I suppose I did a bit of telehealth through Instagram and doing some exercise for runners, but you don't really get engagement back. So yes, up until kind of March, nothing in terms of the telehealth.
Yeah, because I think I follow you on Instagram as well, and I do see sometimes you advertising for your Pilates classes and telling your group when you're gonna have your Pilates, or you got spaces available, and I see some of you doing Pilates outdoors as well, which is quite interesting.
Yeah.
Yeah, so I was like, oh, I wish I was joining them, but I'm just too lazy to bother to be bothered.
See, that's a problem. You've not got the excuse of winter and having to get outside. You can do it in your home. So yes, you've not got that excuse anymore, Chee-Wee.
Yeah, I know. Now COVID has sort of forced me to, unfortunately, engage with physical activity. So what was the push for you to start using telehealth much more broadly?
So essentially, following kind of national guidance, everything kind of shut down, everything stopped. There was a very small, limited clinical group of patients that the CSP would allow us to see, those where we were querying red flag pathology or those with acute flares of rheumatological. Now, I don't really see those groups. I might pick up red flag stuff in clinic, but if anyone was telling me red flag stuff, I wasn't bringing them into clinic. I was sending them on to kind of GPs. So the pushes with service provision had to move online. Otherwise, yes, we wouldn't have had a service to kind of offer. So yes, it was kind of, do or die, I think is the phrase. Yes. So in some ways, kind of the Pilates side of things has lent itself to virtual. Physio side of things, kind of once we moved out of the kind of lockdown phase, guidance from government, from CSP, public health, was to do some sort of telehealth screening and then assess for face-to-face. So that's still very much going on. In fact, I had 2 virtual kind of consults, 1 telephone call, and a couple of face-to-face today in clinic. So it really has kind of meant that you've got to be a bit more dynamic. You've got to kind of learn to kind of go with the flow. Your day is not structured as a traditional day would have been in an MSK clinic anymore. And I have made the mistake of collecting a patient with my earphones still in because I'm being plugged in, and then I've gone into real life and had to apologize and take my earphones out, which is rather embarrassing. Thankfully the patient just said, "Oh, I thought you had them in for a reason." I said, "No, I'm just an idiot." So it has meant that it's just it's absolutely been a necessity, because we're in private practice. It's obviously it's our business, it's our income, so we need to bring patients in and kind of through the door. So yes, it's been a bit of a kind of a mixed challenge. I know we'll probably discuss a bit of the kind of pros and cons as we go on, but yes, very much. And I slightly think there'll be telehealth here to stay in some capacity. Maybe not so much for me in private practice as there would be maybe in the NHS, I don't know, but yeah, I think telehealth is here to stay in a varying capacities.
Yeah. That's interesting. Now, just for the benefit of our of my students, because they are in their first year, you mentioned that for the red flags, patients presenting potentially with red flags. Can you explain a bit to my students, because probably they don't know what you're talking about in terms of red flags?
Fine. So red flag pathology is a method that we use in kind of musculoskeletal medicine, or kind of I suppose probably all kind of physio areas, where the underlying cause of pain, discomfort, dysfunction is not of a kind of a mechanical kind of neuromuscular, like a serious or a sinister pathology. So things that might be included in a kind of a red flag bracket would be things like kind of tumorous kind of causes, bony metastases presenting as mid-back pain, kind of other lesions, other complicated things, abscesses, infections that produce pain, which would make you think, oh, it's a shoulder, but actually the underlying cause is something more serious and sinister. And ultimately, these are things that we don't want to be missing in practice. And to identify red flag pathology, we really rely on our subjective history. And you'll use key questioning, things like how does it present throughout the day? Is it after activity? Is it during an exercise? Is it getting up and on your feet? Or is it there constantly? Is it something that doesn't change? Do they have night pain? Would be a red flag question. Their medical history, have they had kind of previous cancers? We know there's a couple of cancers that kind of can metastasize, and that's when a cancer is of a primary origin, say a tumor in breast, in prostate, in lung, that then moves into kind of cancerous tissue within bone. So these are things like, if somebody's comes into me with kind of thoracic mid-back pain and then says, oh, I had breast cancer 5-10 years ago, instantly I'm thinking, right, okay, has cancer returned? Have we not picked it up? Has it moved? Things you pick up, they'll be referred on, liaising with GP colleagues, medical colleagues. Sometimes things you might seem like a red flag, we get them checked out and it is just mechanical pain, but these are things of a more serious nature that can't be ignored, don't want to delay diagnosis with.
Okay.
Is that kind of clear?
Yeah, because it's just to set the context, because they'll probably be wondering what those are and why you're referring them on. Essentially, is because these situations, these patients are much more complicated, and it's not really for physios. We might make things worse if we actually continue to see them, and which is why we pick these complications up and then refer them on to our medical colleagues who are in a much better position to actually see them.
Yeah, definitely.
So now, you said that you started using telehealth in your private practice, but also in the sort of Pilates. How can you sort of tell us how you actually used it?
Yeah, so I feel like I have been on a technology learning curve that's like, because although I'm tech savvy, I definitely rely on Apple products to keep me right, because I am not a technical person. So quickly having to learn how to take Pilates classes online, and I use Zoom as the platform. Thankfully, actually, I'd already used it a little pre-lockdown. So it was familiarizing myself with Zoom, building a booking system, and getting you're all, we won't see, but on a little tripod and an iPad, getting all of that set up for home so that I could stream from my house into other people's kind of living rooms Pilates classes. And most of my kind of Pilates clients I would have known in a one-to-one capacity. I would have taught in class before, so they know me, they know my style, and I think beauty of being able to beam into people's living rooms is I've actually managed to capture people that maybe wouldn't have felt either comfortable in class or couldn't have accessed class. So for example, a kind of a longer term patient of mine who has kind of chronic multiple pain sites would never have been confident enough to put on leggings, put on a top, get into a church hall, roll out a mat and follow exercise in a group. But actually in the comfort of her own living room, she's more than happy. She keeps her screen kind of closed off so that nobody else can see, but it's been really lovely being able to offer that to her kind of during lockdown. Another lady that has quite severe rheumatoid arthritis. So that rheumatoid arthritis is the kind of inflammatory kind of autoimmune condition which has affected lots of the joints within our hands. So she is brilliant, very active. I've worked with her for a long time. But again, a lot of what class would have entailed might need to be modified. So working at home for her has completely taken the kind of embarrassment out of having to pull out a chair and do a bit of work on a chair. And so for these people, I think, you know, lockdown has been great because it's meant that they've got access to things in the comfort of their own home. But from a kind of a my sided point of view, it's making sure that I had the kit, I had the booking system. What's always important, legality, legislation, my note keeping, my booking, my public liability. I had to make sure all of that was in place as well. A lot of it is kind of already through CSP and through the work, and quite quickly.
Ooh. Hello, Ruth.
Yeah,
I think you're just frozen. Sorry.
A lot of these systems are. Oh, am I back?
Yep.
Yep. Yes. So from my point of view, it's a lot of organising. It's a lot of almost like bringing a service. It's like a service provision. You know, have I set up good communication channels? Have I got a booking system? Have I made sure that everyone knows what time, what place, what we're doing? So yes, a lot of kind of work in the early part of lockdown to get that up and to get that ready.
So with all that work, that was probably front loaded, where during the lockdown you had to figure all these out. And once you figured it out, is it now slightly more smoother in terms of the implementation, or do you still have issues that keeps on cropping up?
No, do you know what? Actually, I've only had one issue with Zoom, and I definitely jinxed it because that afternoon I thought I've not had any issues with Zoom. Booking systems worked brilliantly. That evening I had a wee glitch, but apart from that, you know, so I've been teaching Pilates, albeit 1 week online, since probably about mid-April. No kind of glitches. It's really easy. The systems work because they auto-generate my Zoom links for me. People can book in, people can pay online. So actually my admin side of things, now that it's up and settled, is actually relatively low. The most admin I do is now for new inquiries, new kind of clients.
Okay.
People coming on board.
Do you find online, do you generate the same amount of clients who come to you, or is that, or these clients who come to you are just repeat customers who come back to you because they know you?
Yeah, it's a really good question. That's something I've kind of monitored over lockdown. What I would say, people that have stuck and stick are people that have either a personal connection or have seen me before or have had physio from me before. There's only a handful of people who are kind of completely new and have stuck, because I think that as much as you try and get your personality across, as much as you try and engage, you do miss out on the human factor. So unless you know me, unless you have had physio, unless you've got a kind of connection to me, I find that people that have, you know, in the middle of lockdown that were joining have kind of trailed away and found other things. Maybe it's that they've gone back to gyms, maybe that it's that they didn't love Pilates and don't want to do it anymore. But I think unless you've got a kind of human connection, and I try to kind of build a connection. Anyone that's new that drops into class, I email after class, I check in, I just make sure that, you know, that everything worked, they felt happy, they felt comfortable. So feedback's been really positive, and I think a lot of people that I might have seen in kind of group settings don't want to go back to group settings, not necessarily because of worry about virus, but just like they've got their own kit, they know it's clean, they know their house is heated, they don't need to leave in a cold dark evening to traipse out. There's a couple of ladies that are maybe slightly more elderly who feel much more kind of confident in their own homes. And there's not that kind of worry or angst about coming out to a class that everyone's going to be lycra clad and really bendy and flexible, because, you know, apart from me, if they have their video on, nobody knows what you're doing. Yeah. Which also can be a downside if people are doing something wild and wacky at home. Thankfully, no, and thankfully, no injuries. Kind of been reported at home. No one's standing on their head. Um, there is there's pros and cons. Yeah, I don't know that everyone's doing perfect technique all the time, like I would if I could go around and pod and probe and facilitate and change and correct. But yeah, feedback is good, and for the core, you know, I've roughly got about 20 people in my Monday class, 20 people in my Wednesday class, and for me that's ample, that's ideal, and that's perfect.
So you actually do group classes online?
Yeah, group classes online, and it just would look like, I'm imagining how you will all see you kind of Microsoft kind of Teams. I see lots of little boxes of everyone, little smiley faces at home. But Zoom, if you're familiar with Zoom, you can kind of highlight me, so I would be full screen, and I would be in the center, so that you can get a good view of what I'm asking them to do.
Yeah. Do you ask your clients to share their videos with you so that you can monitor them as well?
Yes, that's a good point. In fact, I've chatted with colleagues. Some colleagues are really like, no, you have to get, and I want them to have their videos on. I sit in the camp where I allow it to be optional. The way I've set my Zoom up is that everyone has their videos off, and they can opt to kind of share their video. I don't know if it's just because I come from a physio NHS confidentiality. I just think, oh, not everyone wants to show their living room, and that's totally fine with me. Those people I maybe check in with, though, make sure everything was okay. I just make sure I have really open channels of communication, and I end class a lot of the time. Any questions, drop me an email, catch me on Instagram, you know, do kind of chat to me. And a couple of people have come back to me and said, like, oh, I didn't quite get that stretch, it didn't work for me. So what I'll often then do is say, right, log in 5 minutes before class, we'll go through it together in a mini one-to-one. It does involve a bit more time, but you know, I kind of like my trade to be that I give people good value, and I want people to be enjoying it. I want them to feel confident. And I think as a physio delivering Pilates, people quite often look to come to physio-led Pilates because they've had specific problems, because they feel really confident and safe that we're not going to be asking them to do anything that will hurt and damage bodies. Now, in reality, my classes possibly aren't that different from a regular Pilates instructor. But yeah, knowing that I'm an MS specialist, knowing that I work with them to fix their shoulder pain gives them confidence in coming to exercise with me. And I think the power of just getting people moving, you know, yeah, just like I want to just stretch the thoracic spines, I want to lift arms up because we've not maybe done that all day. And it's just really good to know that people at home are getting a workout. And I think also the kind of the mental health side of things, you know, we are all frazzled, we have worked hard, it has been a tough year. I build in lots of relaxation to my class, and it's just nice to give people the opportunity to have an hour away from the world as whatever they are dealing with, and focus on their body, focus on breathing, focus on moving.
Yeah. I mean, what are some, you mentioned some of the, a little bit of the challenges and also the benefits of sort of having this virtual sort of telehealth, tele-rehab classes type thing. What are some of the differences or similarities between these sort of virtual online interactions as compared to our face-to-face? Because obviously there will be a lot of differences, but my question is, how similar or how different are they, and what have you done or changed in your own practice to enable that rapport to be constantly built, which you mentioned?
Yeah. So something I think that's really important, I would say I haven't changed between my face-to-face and my telehealth. So our initial contact with clients can be either virtual, as we are here, or a telephone call. Now we know, and it is well evidenced, that giving kind of your clients, your patients, 2 minutes of free uninterrupted speech to say, I've had a sore shoulder, it's been on, and blah, 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 is really important. So I do that in practice, and I do that virtually, even if you're slightly tight for time. A lot of the time, patients will tell you what you need to know if you just listen to that first 2 minutes. So I think it's really important that patients feel well listened to. So it is difficult when you're starting out subjective history. As a junior clinician or as a student clinician, it can feel like you've got to get through a lot. So you can have quite structured kind of, assessments, quite structured kind of prompts to kind of go through questions. But I would say, even if you've got the most structured assessment, give your patients 2 minutes to and let it all out to you, because, they're coming, they want a good listening ear, they want your trust, and, you want them to trust you, and giving them that 2 minutes is really, really important. So yeah, that's not changed virtually or face to face. I would make sure that to do that.
Yeah, Ruth, I think. Yep. Sorry, you carry on.
Oh, sorry, Chee-Wee. No, it just a bit lag. I guess. Sorry, what were you going to say?
I was just going to say what you mentioned about the 2 minute of dedicated time for the patients to say what they need is really important. I was away in Geneva in the World Physiotherapy Conference in 2019, and one of the sessions, it was a big symposium. It was a focus one, and it was the presenter, I forgot her name, but she mentioned that exactly, and she had done some research on that. And it was quite funny because she was citing some of the interviews she had with patients, and asked them, what is it that you, what are some of the benefits, what are some of the things that you like about your physio interaction, and what are some of the things that you think interactions with physios can improve. And one of the, and she put out some quotes where patients were saying, I wish the physio would just stop talking and let me tell them what my issue is.
Oh, and that's completely it. And I think, I think we are so blessed as a physio profession that I think a lot of time in, kind of clinic or kind of, acute settings, we have much more time than some of our other colleagues or medical colleagues. So often you will kind of get, the GP didn't really do any, and you think, right, okay, I'm going to let them have the time because they want to share their story with you. And absolutely, yeah, frustrated if you say, but where is that pain? And what does that feel like? So let them have that 2 minutes worth. And then you can kind of digest and kind of peel through those layers of what they've kind of told you. It's a skill and it's something you will develop. So I remember my first MSK placement as a student taking a good chunk of time on a subjective because I had to get every box asked and checked. Now I can be a bit more fluid. Now I can skip things. Now I know what's important, what's kind of not. But I would say, yeah, give them that 2 minutes. They will tell you a lot of that performer. They will tell you a lot of what you need to know. Most of the time.
Most of the time, yes, I know. So what are some of the benefits you found when using telehealth, telerehab type things?
Yeah, so a couple of things that when I was reflecting on it. So one thing is, you can be anywhere in the world. So the access or the equity of kind of delivering healthcare, is much more even there. I do a Pilates class with my mother-in-law and her kind of her gang up north. They live in rural Aberdeenshire. Now there are physios, there are Pilates, but that's not happening at the moment. But actually for them it's quite an effort to get anywhere. It's half an hour, 40 minutes. So to be able to beam into a couple of homes for them has been ideal. So I think location, wherever you are in the world, and we were kind of discussing a couple of colleagues about, we're going to keep telehealth as an option post-COVID, post everything. If you trip and sprain your ankle whilst in the Maldives, just book an online appointment. Let Ruth have a look. Let her say, actually, no, let's start some gentle. Don't do this. No, you need to go get x-rayed. So that people will be able to get kind of more timely advice, wherever they are in the world. So I think that has been kind of really good. The other things I would say are maybe, and I come from it from a kind of slant in private practice, is appointments can be shorter for people and they're in the comfort of their own home, so they can maybe tap into help and resources maybe from a kind of they can get to it kind of quicker and easier. They don't have to wait on waiting lists. If they only need one appointment, if they only want one appointment, or financially one appointment's all they can afford, they can have that, and then they've got a bit of knowledge and stuff to go away and work on. And because everything is electronic, we can issue online exercise programs, we can direct them via email to instructional videos, and it all has worked pretty well from that side of things.
Okay, so I mean, there was always a flip side to any procedure or method that we use. So what are some of the challenges you faced?
Yeah. So we were just chatting before. Sometimes online, instructing people to do something, range of motion, that doesn't always go so well. And Chee is saying that other places have very rigorous, kind of positioning. So we tend to find that you can only gain so much from a virtual. You can't test power, you can't test end. The Society of Musculoskeletal Medicine is my kind of speciality in MSK. So we like to feel end ranges, we like to feel joints, we like to test power, we like to assess neurology and structures. You can't really do any of that online. You can have a basic look at range of motion, but I would say in the first couple of experiences that I had virtually, I would say I missed bits and pieces, or maybe not missed, but I thought a shoulder looked like it had loads of movement because the person was slightly side onto the camera. When I brought them into clinic, they had no movement. So my diagnosis had rapidly changed from thinking, oh, this person looks like, oh, maybe they've got a kind of tendon problem, to, oh no, you've definitely got a frozen shoulder. So I don't know as a patient how that would feel. I think people are aware that it's not the same. So I don't think anyone's coming in going, oh my gosh, this person doesn't know what she's talking about. But I think in terms of the quality that you can deliver, it isn't maybe quite the same. The other thing, I suppose, is kind of access for the older generation. It's much more difficult. Not exclusively. There are some people that are brilliant, but getting people, have you got Skype? Have you got Zoom? Lots of them don't. So they're much more isolated and excluded from that kind of virtual world than they would be the kind of the face-to-face. And I do think kind of more of the kind of older population they want to come and see you. They're used to attending GP practices in person. They're used to building up relationships and rapport. And the other side of things, not that I've had it particularly much, but it's maybe like language barrier, or kind of education around body barrier. We try not to use jargon, but is it more difficult virtually to understand someone, or more difficult over the phone? I think it possibly is. So there might be another kind of group of patients that have been slightly kind of isolated from accessing services when they're virtual.
Yeah. Okay. I mean, I've got questions, but I thought maybe it's time to open up the session to the students to ask you any questions that they want. Yeah. So students, essentially, you can ask any questions you want to Ruth. And if you like to either raise your hands, and then when I call for you, unmute yourself, or you can post if you're a bit shy, just post your questions onto the conversation tab, and I can ask that on your behalf. We'll just give them a few minutes. Oh, someone who has raised their hand. Let me just check. Kara, can you unmute yourself?
Hi, yeah, sorry, it was taking its time. So my question was, do you think it would be beneficial for students to have like placement in telehealth?
Oh, so perfect time for the connection to drop. Sorry, ask your question again. Sorry, I got placement and telehealth was what the question was.
Sorry. Do you think it'd be beneficial for first year students to have a placement in telehealth?
Oh, that's a good question. Oh, yes. I think I've got lots of sympathies for those of you starting out your careers now, because it is a challenge, and you are trying to rapidly upskill your learning, your questioning, your interviewing of kind of patients. I think probably we will have some sort of capacity for telehealth going forward. Would I recommend that you have a full placement? I think a blended placement would be ideal, where you could have a bit of time with experienced clinicians, get a bit of face-to-face under your belt, but then yes, definitely get used to kind of, you know, using technology, using different mediums. So yeah, I think a blended placement would be really, really great. I know that some of the sites are allowing and have had students back kind of face to face. But I think if you have the opportunity to do a bit of blended working, do take it, because I think if we don't, as a profession, we might get left behind. So yeah, no, I think it's a really good question. I would say, yeah, if you do have the opportunity to do a bit of telehealth, do take it, because it is a definite skill learning to use all this stuff.
Yeah, I would say that, yeah, I think these days, I was looking at some of the placements that's been constructed. It's quite rare that you have a completely purely telehealth placement. Usually the clinician will bring you in for 1 day a week or 2 days a week, and as a combination, as a Ruth, as a blended approach, where or if it's a combination of several students, where there is one practice educator and several students, where a student will come in for a week and they will be in charge of looking at all the case notes and then reporting back to all the other students who are back home online. Obviously, we hope that as the as the vaccines get distributed, that we don't, I mean, the nature of telehealth and telerehab in physio will go back to how will be used in a way that retains all its benefits. But a lot of it, I mean, physio, as Ruth would agree, is very, very hands-on profession. So we will still have that along. So at the end of the day, I think I think it's still a blended approach we will still be taking on. Right. Anybody else has got any questions? Thanks for that, Cara.
One thing I should mention that we didn't talk about in the slide, the down aspect of tele, is just exactly what's happening. Glitches in the system and that stop-start and that kind of flow you lose a little. So that's what's happening. Yeah, just now. So yeah, I forgot to mention that big thing. Most people are used to it. Most people are kind of sympathetic, but yeah, it can mean that your assessments lose their flow, or you lose a little bit of understanding. But
yeah. Let's see if there's anyone who has got a question. Okay. If you have a question, just oh, someone's got a question in the chat. Let me just have a look. So someone's asked, would you recommend getting experience teaching online now to prepare for the future?
So yes, good. Yeah, teaching online, because that's one thing. That's where I almost wonder whether telehealth will, things like cardiac rehab classes. You know, I do quite a lot of work with postnatal, antenatal ladies as well. You know, it's much easier if you've got a little baby to be able to have something beamed into your house. So yes, I think if you have an opportunity to spend a bit of time kind of honing your teaching skills via kind of face-to-face or online, yeah, I definitely would recommend doing it. I think getting confident in front of a screen is definitely, again, yeah, where was my confidence before? Fairly low. Whereas now, kind of, yeah, much more happy being on a screen. It does feel a little weird chatting to the screen and not having somebody there in front of you. So once you've done it a couple of times, getting over the kind of clunkiness or the kind of slight awkwardness. So yeah, if you can get a bit of experience teaching online, kind of, yeah, definitely do.
Yeah, and a follow-up question to that is, how would you then go about getting such experience?
Oh, sorry, Chee-Wee, was that the question? Were you asking how would they go about getting that sort of experience?
That's correct. That was a follow-up question to that. How would they go about getting
yeah,
experience?
here we go. Yeah, that's really really good question. I suppose from a Pilates point of view, to deliver Pilates sessions, you would have to have done your Pilates training. Quite a lot of those Pilates schools though are delivering online training, so that would be one method if you were keen to go down specialising within a Pilates route. I think most of them require a couple of years of kind of student experience before I think you can start your Pilates training as a 4th year.
That's right.
Yeah, there might be other ventures though, things like I used to help with the NAS, which is the National Association. Oh, what's NAS stand for? It's to do the ankylosing National Ankylosing Spondylitis Society. So ankylosing spondylitis is a specific type of arthritis which affects pelvis, spine, and up into the thoracic spine. These NAS groups, they run over the country nationally, and they're physio led, but that might be something that, you know, if you reached out to your local NAS group, I imagine most of them are doing them online. I think from Instagram I've seen that they are delivering online classes, so I'm sure they'd be happy for people to volunteer to do shadowing, exercising, health promotion. You know, one other good way is just get in, do a couple of classes, join a Pilates class, join in a NASCAR class. Similar, there'll be Parkinsonians kind of group, MS groups. You know, a lot of clinicians will be happy to have kind of students shadowing virtually. So, you know, I would just, go there, see what there is, delve in, get confident, do a couple of sessions, and then, you know, if you build up a relationship with the clinician, they might let you start taking like warm-ups and building up a little bit of a kind of an exercise plan or program. So yeah, do a bit of research, see what's in your kind of local area. There'll be lots of places that will be looking for kind of volunteers. I don't know whether there are any kind of local care homes or kind of looking for exercise kind of deliverance, you know, if you can beam me up on a big telly and you can do some chair stretches, chair mobility. I think people would be grateful of your skill, you know, as students in your time. So yeah, go out there, see what there is.
That's great. There's the next question by Emma Claire. Do you think telehealth will become the new norm, even with the vaccine and life getting back a bit back to normal eventually?
Yeah, really good question, Emma. I would envisage as a profession we will have to maintain our screening and our initial contact virtually, probably beyond the deliverance of the vaccine to the mainstream. So I think in healthcare we'll probably lag a little. Will it be the new norm? I would hope at some stage, but my estimations is maybe even about a year from now, we will still be doing initial kind of virtually, then face-to-face after screening, until the point at where, you know, widescreen kind of immunity, lots of people being vaccinated. I don't think it will go back to normal until a bit further down the line from maybe more general things. I would hate it to be the absolute norm. I'd love it as an option to stay there, but I would like just to get back to the point where patients can just phone up, book in, and we can just see them. And but I think realistically a year, 18 months, and I think we'll be existing in PPE for about the same amount of time, even if we are vaccinated.
That's interesting, isn't it? Yeah. So essentially, what you're saying is that right now, that's what is probably what we're going to carry on. But in the longer term, you think that going back to our traditional way of assessing, with a bit of combination of the benefits of telehealth, would be actually the way to go forwards?
Yeah, I think the telephone screening in some ways will we want to keep that as an option, because what we do at the moment in our clinic is a 20-minute telephone call or a virtual appointment. History, subjective, bit of a kind of fact finding, COVID screening to screen them for coming into clinic. But if you hurt your back on a Monday and I didn't have an appointment to a Thursday, you still want a telephone call. So I said, right, okay, this is what to do this. Yeah, I think for some people it might still be a good option. But I think if you've hurt your shoulder, it's low grade, it's grumbling, you're not playing tennis for another fortnight, you can wait till Wednesday. Will you want a telephone call and then to see me if you don't have to? Probably not. But yeah, so I think it's definitely, when we get back to normal, we'll still have a bit of telehealth mixed and blended in there. But yeah, I think for the majority of people, they'll want to just get back to phoning up, booking in, coming and seeing us.
Right. So anybody else has got any other questions for Ruth? We're just going to wait for them. Sometimes it takes a few seconds for them to type it in. I mean, whilst they are trying to think of a question or trying to type in, it's actually worth saying that it is. I mean, I absolutely agree when you were talking about for some of the patients, when they are used to this and the convenience of sometimes having a virtual sort of a consultation, some of them might not want to come back to it, although saying that if they still need hands-on treatment, they still will come into the clinic itself. It's like it's the same like when I'm taking classes with them. It is absolutely convenient for me. I could roll out of bed, go to the kitchen, and just slowly walk to my screen and then start the class, which is compared to previously where I had to take a train to get into campus. I mean, that is so much easier. But I mean, I would agree that personal touch of seeing the students there, having the eye-to-eye contact and seeing their reaction to how they're responding to you. I mean, right now, it's quite difficult for me to know if the students are understanding or paying attention to what our conversation is right now. But if it was in person, I would straight away spot perhaps there's a sudden lag in attention, and then I would throw in something interesting in order to gain their attention again. And that is what I really miss about that face-to-face, which we can't really get from virtual.
No, and I think that the kind of virtual world can feel a bit odd if you have just blank screens. Like I have taken a couple of classes where people haven't put on their videos, and you're like, right, everyone, okay, off you go. Are you even there? You know, kind of, and it does feel a bit odd. So yeah, it's funny the debate about whether, for me, whether I go Pilates group classes. I have a busy schedule. It saves me a lot of time. It saves me overheads of, renting a space, turning up into the gym. Oh, the air conditioner's busted, nobody's told me, and it's leaking water. And the variables are a lot less doing it from home. And will I want to go back face to face, or is at this moment in my life more convenient for me to stay online? Yeah, maybe it is just. Yeah, maybe I'll do one class back face to face, the other will stay kind of virtual. Yeah, it'll be interesting to see where we go. In some ways, from a business point of view, it's been great, it's been good. So will I want I would quite like it to continue as it is, but being realistic, there'll be people that will want to go back face to face.
Yeah, there is a question from Jennifer. She said that you mentioned a patient not facing the screen exactly, thus causing difficulty. I think she was referring to you when you talk about the shoulder range of movement.
Yeah.
Are there any other specific things that might inhibit a virtual examination assessment?
Yeah, really good question, Jennifer. Yeah, so that was dealing with virtuals. That inhibit definitely if screen placement isn't great, if patient space isn't great, trying to do a lumbar spine assessment or how to look at a hip and standing, if all you can see is that bit of the body, or somebody's on a desktop computer and it's not mobile and you can't. I had one of my chaps this morning was on a phone, so he could kind of show me kind of different bits of his body, and we could kind of be quite mobile. But I've had a couple that people have done in like an office chair, and I've said, okay, stand up, and they've gone, right, okay, and they stand up and all you end up seeing is a midriff, and you think, oh, okay, that's not brilliant. Or motion issues or sound and audio issues, and not so much in terms of like, can they hear, but is the quality good, or is there an echo that can really inhibit it, or you that kind of start stop of, oh, I didn't catch you, say that again, have I lost you, I've lost you, come back, can inhibit the kind of the flow. Yes, I hope that answers question. I'm trying to think of other examples when things have not gone right. Just a lot of our special tests, you know, I have tried and played about with, you can do a test for your neurological structures of your lumbar spine. It's called straight leg raise. And I see I'm trying to show you and I can't. You know, when we get a patient to lie down and we actively take their leg up. Now, I've tried to do that a couple of times when I've thought, oh, this sounds a bit neurally. Is this coming off the back? It doesn't work. So you kind of come to the conclusion, it's like, okay, I've kind of muddled through as much as I can, but I still need to see you, or I still need to do your reflexes. So yeah, lumbar spines have been tough. Shoulders have been a bit tough. I'm much better now at kind of accepting what I can and I can't. You know, I've worked out what I can do and what I can't do kind of virtually. Necks are great. They're pretty good to do virtually. But yes, yeah, those limitations definitely do exist.
Essentially, Ruth, what you're saying is that we have to be realistic about what can be achieved, despite the fact that technology might be convenient, and there are some things that can be done better, but there are some, we have to be realistic about what they can actually really achieve. Yeah. So it's again, yeah.
And I suppose in terms of, you know, checking the essentials, you know, making sure our questioning, I think the power of our subjective virtually outweighs the objective, so the physical looking. So perhaps as a kind of junior clinician, as a student, when you don't have that confidence of, all right, I've heard these stories, I've heard these terms, I've seen these patients before, your objective is really important, because you kind of, you know, verify your thoughts and your clinical reasoning with your objective. But actually you can't do that. So you do, and you are relying a lot more on your subjective. And as a kind of inexperienced kind of junior clinician, that's definitely hard. So yes, that's where making sure your questioning is really good, and just accepting that I can only see this, but I've safeguarded, I've screened, I've made sure that I'm not missing any of the real key things. And then if in doubt, you know, I would say that we probably have been using my medical colleagues a bit more. Is that because we're seeing more complicated stuff? Definitely, I think in the last 6 months referred from the most scans, the most onward referrals, the most bloods, the most check. Can you check this? This doesn't sound right. And is that because people have sat on things for 3-4 months and we pick them up and it's a kind of disaster zone? Or is that because these people are seeking out private practice physio because the provision in the NHS is not as much? I'm not entirely sure. But yeah, people just seem a little bit more complicated at the moment, and that can be really hard to do virtually. So I have to say I'm at the point now where I see most of my virtual first contacts will at some stage end up with a face-to-face down the line.
Yeah. Ruth, I'm just aware of time, and I would just someone says they're going to head off for work, but yeah, thank you, Jennifer. Now, Ruth, you and I are involved in different capacities with this organization called Society of Musculoskeletal Medicine. I was just wondering, as a sort of ending off, would you like to tell the students a bit about SOM?
Yeah, of course. So yes, SOM, Society of Musculoskeletal Medicine. It exists off the back of the teachings of an orthopedic kind of musculoskeletal doctor called Dr. Syriacs, who worked down in kind of London, who basically kind of devised a kind of clinical reasoning, a model assessment, and then kind of techniques. Where it is now is it's much more evidence-based. We brought it up and into kind of like the here and now. What is best practice? It would still follow a very kind of kind of very methodical, logical, subjective, and then a very methodical objective, where we look at ranges of movement, passive to feel for end feels, which can give us an idea of what's going on within the structures, inert structures, and selective tissue tension tests and muscle power tests in a mid-range isometric hold, so to check for contractile lesions, layering in special tests, and then helping to find our clinical reasoning, hone our clinical reasoning to come up with a kind of lesion diagnosis and then a treatment kind of plan. And some kind of in 2020, January 2020, delivering kind of face-to-face weekend kind of CPD work courses which have a master's accreditation to them. And so great if you were like me and are about to, well, hopefully finish my MSc, that those kind of carry weighting if you do want to go down that line, but they can exist as standalone kind of courses. As a society, everything's been brought online, and we've been delivering online kind of courses. So again, they're much more theory based. You don't get to feel a model, you don't get to have a practice. So we've kind of split up things so that you've got a chunk of online delivery, and then when we're kind of safe to do so, bring that into the kind of physical kind of teaching. Courses are run all over the kind of the country, and at the moment the MSc pathway is being validated by QMU, so it's based kind of up here in kind of Scotland. It's all virtual and remote though, and the kind of the lead for the MSc are two really fabulous experienced clinicians, not me, someone else. So yeah, I mean, if you are interested in some courses postgraduate, I did them a couple of years into clinical practice, and at a great point where I was specialising kind of in MSK, and yeah, I haven't really looked back. I divulge, I bring in Pilates, I bring in other bits and pieces, but the bones of my assessment will always be a SOM assessment, and you can kind of, you don't miss things with SOM is what I would say.
Yeah, and also something that probably the students probably don't know is that SOM also teaches injection therapy as well. I'm just wondering, you want to mention that?
Yes, yeah, I forget about injection therapy because that's just kind of stopped. But yes, injection therapy. So teach kind of yeah, physios and GPs, and it is actually, SOM is open to any kind of healthcare professional now. So GPs, doctors, people with interest in sports medicine, physios, I think podiatrists. So there's many more people that could pull into kind of SOM. But yeah, injections. There's a pathway exists for what we call first contact practitioners, who are people who are working in kind of GP centre to provide intervention. So a lot of the MSK services are looking to employ these first contact practitioners into roles to kind of help with waiting list management, to help offload burden of MSK services and GPs, because we know that a lot of footfall through GP practice could be and is really well suited to be seen by a physio, because a lot of it's MSK.
That's great. Ruth, thank you so much for your time and sharing your experiences with my students. It was really valuable, and it's always nice to have colleagues come in and chat with our students about their experiences. Students, can I kindly ask all of you to raise your hands in order to thank Ruth, please, because there's no hand clap symbol. Thank you very much.
I feel like lots of hands have gone up. I feel like, yeah, it's sort of like a virtual disco.
Yes, that's right. Right. Thank you very much. Now, guys, for next week, there is no classes on for next Tuesday, so it would be a good idea to maybe ask you, would you like the week off in order to prepare for your coursework, or would you like me to have retain that Tuesday session, and then you can come in and ask me question answers for your coursework? So you can type into the chat to tell me what you want, and then I'm quite happy to come in next Tuesday. Keep the class for questions. Okay, that's fine. So yeah, Q&A, that's absolutely fine. I'm quite happy to do that. So I will see all of you next Tuesday, same time, same place on Collaborate Ultra at 2 p.m. And bring your questions along so that I can answer any questions that you have. Okay. So thank you, everyone. And thank you, Ruth, so much.
Thanks, everyone. Thanks. Bye.